Welcome to the Deep Dive. We're here to cut through the noise and get straight to what matters. Today, we are plunging into, well, one of the most astonishing journeys the human body can undertake, pregnancy. Just imagine a 9-month symphony of transformation. It's not just about a baby growing, but a complete remodeling of the maternal system itself. And for you, our future healthcare providers, immersing yourselves in maternity nursing, our mission today is to unpack these complex physiological shifts. We'll cover the essential antepartum assessment and care, and the absolutely crucial role of nutrition. We've distilled insights from a comprehensive nursing guide for childbearing patients and families, plus a detailed study guide. This deep dive is really designed to arm you with the foundational knowledge you need, so you can confidently understand and care for pregnant clients, equipping you with the why behind the what so it actually sticks. All right, let's dive in. Imagine you're a new nurse stepping onto a maternity ward, first time. The sheer volume of information, it can feel overwhelming, right? But what if we told you there's a kind of secret language, a shorthand that unlocks a client's entire pregnancy story in just a few letters? That's where we'll begin today. Mastering the essential vocabulary of maternity care.
Absolutely. These terms, they're like crucial shortcuts for quickly understanding a client's obstetric history. They paint a picture with just a few words. For instance, gravid. It simply means the state of being pregnant. And gravida, or gravidity, that refers to the total number of times a client has been pregnant. And that's regardless of the outcome, whether it was carried to term, ended in miscarriage, or is even the current pregnancy. So a nulligravida has never been pregnant. A primigravida is pregnant for the very first time. And a multigravida, well, she's been pregnant 3 or more times.
Okay, so gravida gives us the full pregnancy count. What's the key distinction then when we talk about para? How does that refine our understanding?
That's a great question because para or parity is often where, confusion can creep in. It specifically refers to the number of times a client has given birth to a fetus at least 20 weeks gestation. And that's whether that baby was born alive or not. The critical point here is that multiple births, like twins or triplets, they still count as one single birth event for parity. Just one.
Okay. One event.
Right. So a nullipara has never had a viable offspring, often shortened to primip. And a multipora, or multip, has delivered 2 or more fetuses after that 20 weeks gestation mark.
Got it. So together, gravida and para give you that quick, comprehensive snapshot. Now, moving beyond the vocabulary, let's zoom out a bit. Look at the whole pregnancy journey in its 3 trimesters. The first, weeks 1 to 13, it's all about that incredible fetal organ development, super critical phase.
Yeah, absolutely foundational.
Then, from weeks 14 to 27, that's the second trimester, we see significant maternal tissue growth then.
Right. The body's really building up its own resources.
And finally, weeks 28 to 42, the third trimester, that's dedicated to rapid fetal tissue growth and, well, preparing for birth.
It's truly a marvel how the body adapts across these stages. It really is. And speaking of adaptation, this is where the real magic happens. The widespread body system changes. Let's start with the reproductive system. The uterus, for instance, undergoes just astonishing growth. Instead of trying to memorize every single landmark, maybe think of it this way. By the time your client is roughly halfway through her pregnancy, around 20 weeks, that uterus has already expanded enough to reach her belly button.
Right up to the navel.
Exactly. And by 36 weeks, it's pressing right up against her ribs.
Which totally explains why breathlessness becomes so common later on, right? The uterus is literally pushing against the diaphragm.
Precisely. And then around 40 weeks, the fetal head often descends into the pelvis. That's a process called lightening, which, as you said, can sometimes ease that shortness of breath a little. Gives a bit more room.
Makes sense.
The cervix also shows significant changes. It forms a protective mucus plug, a really important barrier. And you'll observe 2 probable signs of pregnancy there. Chadwick's sign, that's the bluish discoloration, and Goodell's sign, which is the softening of the cervix itself.
Okay, Chadwick's blue, Goodell's soft.
Got it. Another probable sign, ballottement, is where an examiner can feel the fetus rebound when gently tapping the cervix during an internal exam. And of course, the breasts increase in size and the areolas darken, preparing for lactation. Obvious changes there.
Okay, now here's where it gets really interesting, especially for your clinical practice. The cardiovascular system. We see significant increases in cardiac output and blood volume, huge increases. It's like the pregnant body is preparing for, an epic marathon and a major blood donation at the same time. What's the reason for this surge?
It's brilliant, really. That surge in cardiac output and blood volume isn't just about feeding too. It's a physiological masterclass in self-preservation, you could say. The body is literally stockpiling fluid and making the heart work harder to buffer against the blood loss that's pretty much expected during delivery. It's anticipating it.
Wow.
Yeah. You'll also see the heart rate increase by about 10 to 20 beats per minute by 32 weeks, and it stays elevated.
That's wild.
Yeah.
But despite all this extra volume, blood pressure doesn't necessarily skyrocket. It almost seems counterintuitive. What's the body's clever trick there?
That's due to a decrease in systemic vascular resistance. Hormone influences cause vasodilation, basically widening the blood vessels,
Yeah.
which helps prevent dramatic increases in blood pressure despite all that increased blood volume.
Okay, so the pipes get wider.
Exactly. But this vasodilation can contribute to lower extremity edema, so that swelling you might see in the ankles, it's often normal. Now, on top of all this blood volume, the body also shifts into what we call a hypercoagulant state. Essentially, it's like the blood's clotting ability goes into overdrive.
Right, to prevent bleeding at birth.
Exactly. A clever evolutionary design to minimize bleeding during birth. But the flip side is it also means a significantly increased risk for dangerous blood clots. Things like deep vein thrombosis or DVT. That's something every nurse absolutely must keep top of mind. Really critical.
Which brings us neatly to supine hypotensive syndrome. This is a critical condition for pregnant clients and something you will see. What happens here and why is it so important for nurses to understand?
Right. So when a client lies flat on their back, especially later in pregnancy, the weight of the enlarging uterus puts pressure on the vena cava. That's the major vein returning blood to the heart.
Compresses it.
Yes, compresses it. This reduces blood flow back to the heart and can lead to maternal hypertension, low blood pressure. Signs you'll observe include dizziness, lightheadedness, pallor, maybe clammy skin, or even syncope fainting.
So what do we do?
As a nurse, patient education is absolutely vital. Emphasize avoiding lying flat on their back. Encourage getting up slowly, and advocate for left lateral side positioning. Lying on the left side takes the pressure off the vena cava and optimizes blood flow for both mom and baby. Best practice.
Got it. Left side lying.
Okay.
Okay, let's move to the respiratory system. Oxygen consumption increases by 20% in pregnancy. That's quite a jump. And the respiratory rate increases, especially in the third trimester. What's going on internally to cause this?
Well, in the third trimester, that growing uterus is pushing upward on the diaphragm, right? So it physically decreases lung capacity. There's just less room. The body compensates brilliantly, though. Progesterone actually acts as a respiratory stimulant, increasing the rate of breathing.
Progesterone again.
Yep, it's everywhere. This allows the client to get enough oxygen for both themselves and the fetus, even with less lung space. But it commonly results in dyspnea, or that feeling of shortness of breath. Very common complaint.
That makes total sense. And the gastrointestinal system, what should nurses anticipate there? Heartburn.
Oh, definitely heartburn. The upward displacement of the stomach and decreased tone of the esophageal sphincter commonly lead to pyresis. That's the medical term for heartburn and acid reflux. And progesterone, again, relaxes smooth muscles throughout the body, including the gut. This decreases motility and slows digestion, which very often results in constipation. Super common.
And gallstones.
Yes, there's an increased risk. The gallbladder can become hypotonic, meaning less muscle tone, with prolonged emptying time. Bile thickens, and that increases the risk for gallstones. So, yeah, your role here is all about patient comfort and education on managing these things.
What about the urinary system? I think we all assume more frequent trips to the bathroom.
Absolutely. That increased cardiac output leads to an increase in renal plasma flow and urinary output. So urinary frequency is a very common complaint, especially early and late in pregnancy. The kidneys also retain extra water and salt to increase that blood volume we talked about, which actually causes the blood to become slightly diluted, a bit of hemodilution. And, you guessed it, progesterone relaxes the ureter and bladder muscles too. This can lead to urinary stasis, urine sitting around longer. And unfortunately, that increases the risk for urinary tract infections, or UTIs. Recognizing these common changes helps you distinguish normal from abnormal.
Right, knowing the baseline. Okay, next, the integumentary system, the skin. Why do pregnant clients often feel warmer and perspire more?
That's due to increased skin circulation. It helps dissipate the excess heat produced by their increased metabolism. Their internal furnace is turned up a bit. You'll also often see hyperpigmentation due to elevated hormone levels, things like chloasma, sometimes called the mask of pregnancy on the face, and linea nigra, that dark line that can appear from the umbilicus down to the pubic area.
And stretch marks.
And of course, striae gravidarum stretch marks, commonly found on the abdomen, breasts, and thighs. Very normal.
Okay. And the musculoskeletal system. The body's entire balance shifts dramatically, doesn't it? I imagine falls are a risk.
They are. Body changes affect posture, gait, and balance. The center of gravity shifts forward as the uterus grows. This definitely increases the risk for falls and sprains. Posture changes often include a sway back that increased lumbar curve to compensate for the enlarging abdomen.
The pregnancy stance.
Kinda, yeah. The hormone relaxin also does its job, relaxing ligaments and pelvic joints. This contributes to what's commonly called a waddling gait later in pregnancy. And sometimes you'll see diastasis recti, which is the separation of the abdominal muscles right down the middle.
Lastly, for systems, just a quick note on the endocrine system. The hormonal symphony is, of course, central to all these changes we've discussed.
Indeed. It orchestrates everything. Key hormones include HCG, that's human chorionic gonadotropin, which maintains the corpus luteum early on until the placenta takes over progesterone production. Then you have progesterone itself, estrogen, relaxin, prolactin for milk production later, and human chorionic somatomammotropin, or HCS.
And estrogen.
Estrogen levels rise significantly throughout pregnancy. They play a huge role. Then they begin to fall quickly just as birth approaches, which is thought to be one of the signals for labor to begin.
Fascinating interplay. Before we move on, let's just quickly touch on vital signs during pregnancy. What should we expect to see as nurses, and why does knowing the normal matter so much?
Good point. For heart rate, expect that increase of 15 to 20 BPM by around 32 weeks. Remember, the heart's working harder. Respirations might increase slightly in third trimester, as we discussed. Blood pressure is the interesting one. Systolic usually shows no significant change, but diastolic typically has a slight decrease, maybe 5 to 10 millimilli Hg during the second trimester.
Why the dip then?
That's a result of that peripheral vasodilation caused by progesterone. The blood vessels are more relaxed. It usually returns to pre-pregnancy levels in the first and third trimesters. Knowing these normal changes is absolutely vital. It's your baseline for spotting abnormal ones that could indicate complications like preeclampsia. Can't stress that enough.
That's a crucial point for nurses. Okay, now that we understand the physiological shifts, let's talk about confirming pregnancy and initiating antepartum care. The blueprint for health. We categorize signs of pregnancy into 3 types: presumptive, probable, and positive. Can you break those down? Focus on what each means for your assessment.
Certainly. Presumptive signs are subjective changes the client suspects are pregnancy-related. They're what might make someone think, maybe I should take a test. Examples include amenorrhea missing a period, fatigue, nausea and vomiting, urinary frequency, breast tenderness, maybe some skin hyperpigmentation, and quickening. That's the first fetal movement felt by the mother, typically around 16 to 20 weeks. These are important clues, but they can definitely have other causes.
Got it. So things the client feels but aren't definitive proof. What about probable signs? They sound a bit more concrete.
They are more objective. Probable signs are changes observed by an examiner that strongly suggest pregnancy, but still aren't 100% definitive proof. These include things like uterine enlargement that the provider can feel, Goodell's sign, soft cervix, Chadwick's sign, bluish cervix, ballottement, also Braxton-Hicks contractions, which are like practice contractions, palpation of the fetal outline through the abdomen. And here's the surprising one for many. A positive pregnancy test also falls into this category.
Wait, a positive pregnancy test is only a probable sign. That might surprise some people who think it's absolute confirmation.
It's because the test detects human chorionic gonadotropin, or HCG, which is produced after implantation. While it's highly indicative, in very rare cases, certain medical conditions or even some medications can also produce HCG. Plus, the level of HCG matters. High levels might suggest a multifetal pregnancy or maybe a genetic abnormality like Down syndrome. Low levels could indicate a miscarriage or an ectopic pregnancy.
So it's a strong clue, but needs context.
Exactly. It highlights why clinical judgment and further assessment are always necessary. We don't rely on just one sign.
So what are the truly positive signs then? The ones that leave absolutely no doubt?
Positive signs are objective findings that can only be attributed to pregnancy. These are the gold standard, the definitive proof. Things like auscultation of fetal heart sounds actually hearing that distinct fetal heartbeat with a Doppler or fetoscope, visualization of the fetus via ultrasound, seeing is believing, or fetal movements that are actually felt and confirmed by the examiner, not just reported by the client. Those are undeniable.
Okay, undeniable proof. Once pregnancy is confirmed, that initial prenatal visit really sets the stage for comprehensive care. What are the primary objectives of this first antepartum visit that nurses will be contributing to?
It's a really important visit. The main goals are to establish trust and rapport, building that relationship from the start. Verifying the pregnancy, obviously. Evaluating the client's physical and psychological health. Assessing the growth and health of the fetus, even early on. Crucially for you as nurses, it's about establishing baseline data, vital signs, weight, lab results, things you'll compare against later. Also evaluating psychosocial needs, support systems, mental health, safety, and assessing any immediate needs for counseling or teaching. It's really a holistic assessment to kickstart the journey properly.
A huge part of that initial visit and ongoing care is accurately documenting obstetric history. We use a couple of systems for this, right? The GP system and the more detailed GTPL system. This is a core skill for you, our listeners.
Correct. Super important shorthand. The gravida par, or GP, is a simple two-digit system. G for gravida is the total number of pregnancies. P for para is the number of births at least 20 weeks gestation. Remember, multiples count as one birth event here. But for a richer, more comprehensive picture, we use GTPL. This is a 5-digit system, gives more detail.
Okay, break down GTPL for us.
Right. G is gravida total number of pregnancies, including the current one. Easy enough. T stands for term births, all births delivered at 3707 weeks gestation or later. P is preterm births, all births delivered between 27 and 67 weeks gestation. A is abortion. This includes all pregnancy losses before 27 weeks, whether spontaneous, like a miscarriage, or induced, like medical or surgical abortions. And L is living the total number of currently living children.
Okay, let's run through a quick practice example for GTPL. This is key for you to grasp. Say we have a 30-year-old client who is currently 25 weeks pregnant with twins. That's her current situation. Her history. She has 5 living children. 4 of those were born at 39 weeks gestation term. 1 was born at 27 weeks gestation, preterm. And 2 years ago, she had a miscarriage at 10 weeks gestation. What's her GTPL?
Okay, let's break it down. G gravida. She has the current twin pregnancy, counts as 1, plus the 5 previous births, plus the 1 miscarriage. So G is 7. Total pregnancy equals 7. T term. She had 4 children born at 39 weeks, so T is 4. P preterm. She had 1 child born at 27 weeks, so P is 1. A abortion. She had 1 miscarriage at 10 weeks, so A is 1. L living. She has 5 living children currently, so L is 5. Her GTPL would be G7, T4, P1, A1, L5.
G7, T4, P1, A1, L5. Perfect. Mastering this is invaluable for quick, accurate communication in any clinical setting. Seriously, practice this.
Absolutely. It tells a story instantly.
Another key calculation is the estimated due date, or EDD, often using Nagel's rule. How do we do that, and why is it still used so frequently in practice? Seems a bit old school, maybe.
It might seem old school, but it's simple, requires no tech, and it's surprisingly accurate for many people, especially those with regular cycles. The method. You determine the first day of the client's last menstrual period, LMP. You need that date. Then subtract 3 calendar months, and finally add 7 days. Adjust the year if necessary.
Okay, example time. LMP was February 15th.
Okay, Feb 15th. Subtract 3 months takes you back to November 15th, add 7 days. The EDD is November 22nd.
What if the LMP was, say, July 7th?
July 7th. Subtract 3 months is April 7th. Add 7 days is April 14th. But since we crossed the year end, the EDD would be April 14th of the following year.
Got it. It's a quick, reliable estimate that gives everyone, the provider, the client, the nurse, a target date to work with.
Exactly. Ultrasound dating is often used too, especially early on, but Nagel's rule is still a standard part of the assessment.
And assessing fetal growth often involves fundal height measurement. What's the purpose and technique here, and what's that key landmark for nurses to remember?
Fundal height helps estimate gestational age and track fetal growth over time. It's a low-tech way to monitor progress between ultrasounds. The technique involves measuring in centimeters from the top of the symphysis pubis, the pubic bone, up to the fundus, which is the very top of the uterus. Your key landmark to remember. The fundus is typically palpable right at the umbilicus, the belly button, around 20 weeks gestation. That's the halfway point marker.
Okay, 20 weeks at the belly button. Good visual.
Right. And after 20 weeks, The fundal height in centimeters roughly corresponds to the number of weeks of gestation, give or take a centimeter or two. So at 24 weeks, you'd expect it to be about 24 centimeters.
Useful rule of thumb.
Uh-huh.
Okay, we also have a whole series of routine labs during pregnancy. Instead of just listing every single one, what are maybe 2 or 3 of the most critical tests you want our listeners to really understand the why behind? The ones you absolutely need to track.
Absolutely. Let's focus on the big ones. First, the CBC complete blood count. This is crucial because it screens for anemia, specifically iron deficiency anemia, which is super common in pregnancy due to that increased blood volume diluting the red cells. It also screens for infection by looking at white blood cell counts.
Okay, CBC for anemia and infection. Makes sense.
Second, blood type and Rh factor. This is non-negotiable. We absolutely need to know if the client is Rh negative. As we'll discuss more, Rh incompatibility can profoundly impact the health of future pregnancies if not managed correctly.
Critical for preventing issues down the line.
Exactly. And third, let's pick the urinalysis. It's simple, but provides so much information. It can help confirm pregnancy early on by detecting HCG. It screens for asymptomatic bacteriuria, which can lead to kidney infections if untreated. And it checks for protein and glucose, which can be early signs of gestational hypertension or gestational diabetes. Early detection is key for all of these.
Great choices. High-yield tests. And for gestational diabetes, there's usually a 2-step screening process, right? The 1-hour glucose challenge and then possibly the 3-hour oral glucose tolerance test.
Yes, that's the standard approach in many places. The 1-hour glucose challenge test, or GCT, is a screening test for hyperglycemia. It's typically done between 24 and 28 weeks gestation. The client drinks a sugary drink and blood glucose is checked 1 hour later. No fasting is needed for this initial screen.
And if that's high?
If the result is elevated, usually above a threshold of 130 to 140 mg/dL, though cutoffs vary slightly by institution, then the client requires the follow-up 3-hour oral glucose tolerance test, or OGTT.
Which is a fasting test.
Correct. For the 3-hour test, the client fasts overnight. They come in, have a baseline fasting blood draw, then drink an even more concentrated glucose drink. Blood is then drawn at 1, 2, and 3 hours after finishing the drink. A diagnosis of gestational diabetes mellitus, or GDM, typically requires 2 or more of those blood glucose readings to be elevated above specific thresholds. As a nurse, you'll be teaching clients about this process, the prep, and what the results mean.
Okay. Now, one of the most critical interventions specifically for Rh-negative clients is RhoGAM. You mentioned the Rh factor earlier. Can you explain why this is so important? It's almost like an immunological shield for future pregnancies, right?
It truly is. It's a fantastic example of preventative medicine in obstetrics. So the Rh factor is just a protein found on the surface of red blood cells. Most people have it. They're Rh positive. Some don't. They're Rh negative. The problem arises if a pregnant client is Rh negative and their fetus inherits the Rh positive factor from the other parent and is therefore Rh positive.
So mom is negative, baby is positive.
Exactly. During pregnancy, or more commonly during birth, some of the fetus's Rh positive blood cells can leak into the mother's Rh negative circulation. Her immune system sees these Rh positive cells as foreign and starts making antibodies against the Rh factor protein. This process is called sensitization.
Does that harm the first baby?
Usually not significantly in a first pregnancy because the antibody response is usually slow and produces lower levels initially, often after delivery. But the danger is for subsequent pregnancies. If that now sensitized Rh negative client carries another Rh positive fetus, her immune system is primed. It will mount a much faster and stronger antibody attack. These antibodies can cross the placenta and destroy the fetus's red blood cells, leading to severe anemia, jaundice, heart failure, and even fetal death. This is called hemolytic disease of the fetus and newborn.
That sounds devastating. So how does RhoGAM prevent this?
RhoGAM is basically a preparation of Rh antibodies. When it's injected into the Rh negative mother, these preformed antibodies quickly find and neutralize any Rh positive fetal cells that might have entered her circulation before her own immune system gets a chance to recognize them and make its own long-lasting antibodies. It essentially tricks her immune system, preventing sensitization from occurring. It's an amazing intervention.
So it's all about protecting those future Rh positive fetuses. When is RhoGAM typically given? Is it just once?
No, there are specific times. First, remember it's a blood product, so it requires careful handling and usually a 2RN check before administration, typically via intramuscular injection. It's given prophylactically, meaning preventatively, to all Rh-negative pregnant clients around 28 weeks gestation. This covers potential small bleeds during the third trimester. It's also given anytime during pregnancy if there's an event that could cause fetal blood cells to mix with maternal blood. Things like abdominal trauma, invasive procedures like amniocentesis, or any episode of vaginal bleeding.
Okay, 28 weeks and after potential mixing events.
Right. And crucially, it's given again within 72 hours, 3 days after birth, but only if the baby is confirmed to be Rh positive. If the baby is Rh negative like the mom, then no postpartum dose is needed.
So you need to know the baby's blood type quickly after birth.
Absolutely. Your role as a nurse includes educating Rh-negative clients about why ROJAM is important, the schedule, and critically, telling them to notify their provider immediately if any vaginal bleeding or abdominal trauma occurs during pregnancy so they can get an extra dose if needed.
That's a powerful intervention and crucial patient education piece. Beyond specific medical things like ROGAM, health promotion is a huge part of antepartum care, guiding clients toward healthy choices. What are some of the absolute non-negotiables you'll be teaching?
Some key messages are really vital. We emphasize avoiding all over-the-counter medications, herbal supplements, and even prescriptions unless they've been specifically discussed with and approved by their OB provider. Many common things are not safe in pregnancy.
Good point. Always check first.
Always. And alcohol is absolutely contraindicated. There is no known safe amount of alcohol during pregnancy. It can cause severe birth defects, known as fetal alcohol spectrum disorders, just zero alcohol.
Zero tolerance.
Zero tolerance. Similarly, tobacco use should be strongly discouraged and cessation supported as it's linked to low birth weight, preterm birth, and other complications. And obviously, any illicit substance use is harmful and needs to be addressed with support and resources.
Okay, those are the big don'ts. What about the do's?
On the positive side, we encourage regular, moderate exercise, assuming no medical contraindications. About 30 minutes a day of activities like walking or swimming is usually great. Clients should avoid activities that could lead to overheating, like hot tubs and saunas, especially early in pregnancy. And hydration is key. Encourage drinking at least 10 cups, that's 80 ounces, of fluid daily, mostly water. These are your core health promotion teaching points. Simple, but impactful.
Great overview. Now let's be real. Pregnancy isn't always comfortable. Let's talk about the common discomforts, because your role as a nurse will absolutely involve providing patient teaching for prevention and relief. We won't list every single one, there are many, but let's highlight a few of the most impactful, starting with nausea and vomiting, often called morning sickness, though it can happen anytime. What are the key dietary education points there?
Nausea and vomiting are incredibly common, especially in the first trimester, due to hormonal shifts. It can really impact quality of life. Advise clients to eat small, frequent meals or snacks every 2 to 3 hours. An empty stomach often makes nausea worse, so keeping something in the stomach helps. They should try to avoid alcohol, caffeine, and especially fried, fatty, or very spicy foods, as these can be triggers.
What about fluids?
Interestingly, suggest avoiding drinking excessive fluids with meals. Sometimes drinking fluids between meals is better tolerated. Filling the stomach with both food and liquid at once can worsen nausea for some. Offering ginger can be really helpful. Things like ginger ale, real ginger, ginger tea, ginger candies, and some find relief with herbal teas like peppermint or raspberry leaf tea, though always check with the provider about herbs.
Good tips. And for constipation.
Yeah.
Also super common due to that progesterone effect slowing down the gut, right?
Exactly. Progesterone relaxes the smooth muscle of the bowel. For constipation, the keys are increasing fluids. Remember that 80 ounces a day and including extra fiber in the diet. Encourage fruits, vegetables, whole grains, legumes. Fiber adds bulk and helps things move along. Also, encouraging safe physical activity, even just regular walking, can significantly improve bowel motility and regularity. These are simple lifestyle interventions that make a big difference for client comfort. Simple, but effective. Okay, now shifting gears to something critically important. Danger signs during pregnancy. These are red flags. These signs warrant urgent medical attention, and it's crucial for patient safety that you, the nurse, know them cold and can teach clients about them effectively. Give us the top-tier must-know red flags.
Absolutely crucial knowledge. These signs mean call your provider immediately or potentially go straight to the emergency room. No waiting. Top of the list, any vaginal bleeding. Doesn't matter if it's light or heavy, it needs evaluation. Also, leakage of fluid from the vagina. Could it be ruptured membranes? needs checking.
Bleeding or fluid leakage. Got it.
Significant swelling, particularly if it's sudden, like rings suddenly becoming tight on fingers or noticeable puffiness of the face or around the eyes. This could signal preeclampsia, a continuous pounding headache that doesn't go away with rest, or typical remedies like Tylenol, acetaminophen, or any visual disturbances, blurred vision, seeing flashing lights, spots before the eyes. Also potential signs of preeclampsia.
Headache, vision changes, swelling. Classic preeclampsia concerns. Exactly. And of course, seizures. That's eclampsia, a true emergency. Also, any persistent or severe abdominal pain, especially if it's in the upper abdomen or epigastric region, fever or painful urination, could be a kidney infection, these all need immediate attention.
What about changes related to the baby or labor?
Yes, definitely. A significant change in the frequency or strength of fetal movements compared to the baby's usual pattern. The client knows their baby best. A sudden decrease needs checking urgently. Also, any signs of preterm labor before 37 weeks. Things like regular uterine contractions or cramping, a constant or irregular low backache that's different from usual pregnancy backache, pelvic pressure, or a sudden increase or change in vaginal discharge, especially if it becomes watery.
Okay, fetal movement changes, preterm labor signs. Anything else?
Yes. Also be aware of signs of uncontrolled blood sugar, which can happen with GDM, signs of hyperglycemia, high blood sugar like excessive thirst, frequent urination, extreme hunger, and signs of hypoglycemia, low blood sugar, like feeling shaky, clammy skin, pale, weak, jittery, irritable, or lightheadedness, all warrant urgent medical attention or guidance from their provider. Your quick recognition and action here can prevent serious complications for both mother and baby.
Extremely important list. Knowing those danger signs is non-negotiable. Okay, beyond discomforts and danger, let's talk weight gain and nutrition. They are foundational to a healthy pregnancy. What are the general weight gain recommendations based on pre-pregnancy BMI, and why do they vary so much? It's not one size fits all.
Definitely not. The recommendations vary significantly because they aim to optimize outcomes, like reducing risks of preterm birth, low birth weight, or conversely, large babies and C-sections based on a client's starting point, their pre-pregnancy health status reflected by BMI. So for clients who start out underweight with a BMI less than 18.5, the recommendation is to gain the most. 28 to 40 pounds. They need to build reserves. For a client starting in the normal weight range, BMI 18.5 to 24.9, the typical goal is 25 to 35 pounds.
That's the range most people hear about.
Right. For clients starting overweight, BMI 25 to 29.9, the goal is lower, 15 to 25 pounds. And for clients starting with obesity, BMI 30 or greater, the recommended gain is the lowest, 11 to 20 pounds. The focus is on nutrient-dense foods, not just calories. Also worth noting, adolescents who are still growing themselves often need to aim for the upper end of their recommended weight gain range.
That makes sense, gaining appropriately for their starting point. And what's the general pattern or rule for how that weight gain should be distributed across the trimesters? Is it steady?
It's not entirely steady. Typically, weight gain is slower in the first trimester, often just about 2 to 4 pounds total. Some might even lose a little weight initially due to nausea. Then, in the second and third trimesters, the gain becomes more consistent, averaging approximately 1 pound per week. It's a gradual, steady increase during the time of major fetal growth and maternal tissue expansion.
Okay, about a pound a week after the first trimester. Good guideline. That brings us right to nutrition during pregnancy, truly fueling two lives. What are the key increases needed? What essential nutrients are we talking about that you'll be educating clients on constantly?
The big picture is that clients need to increase both their overall calorie intake, though not necessarily eating for two in terms of quantity, and definitely their protein intake to support tissue building for both mom and baby. In terms of specific essential nutrients, top of the list is folic acid or folate. It is absolutely crucial, especially before conception and in early pregnancy, for decreasing the risk of neural tube defects like spina bifida. All women of childbearing age should ensure adequate intake.
Where do they get folic acid? Supplements.
Supplements are often recommended, especially preconception and early on. Good food sources include fortified grains and cereals, plus naturally in green leafy vegetables like broccoli, spinach, and kale, beans, and citrus fruits. Next is iron. Increased blood volume means increased need for iron to make hemoglobin. Iron deficiency anemia is common. Iron supplements are frequently prescribed.
Any tips for taking iron supplements that can be rough on the stomach?
Yes, good point. Tell clients to take iron with vitamin C like a small glass of orange juice as vitamin C enhances absorption. Conversely, milk, calcium supplements, antacids, and caffeine can interfere with iron absorption, so avoid taking iron with those. Take it between meals if possible, though some need to take it with a small snack to reduce stomach upset.
Yeah.
Iron-rich foods include red meat, poultry, fish, beans, lentils, and fortified cereals.
Okay, folic acid, iron. What else?
Calcium is vital for fetal bone and teeth development and also for maintaining the mother's bone density. Needs increase, especially in the third trimester. Taking calcium with vitamin D helps increase absorption. Good food sources are dairy products like milk, yogurt, and cheese, fortified juices and plant milks, and leafy greens like kale. Again, caffeine can increase calcium excretion, so moderation is key.
Folic acid, iron,
Yeah,
calcium,
got it.
and hydration.
Still key. At least 10 cups or 80 ounces of fluid per day, mostly plain water. Adequate hydration helps prevent constipation, UTIs, and preterm labor.
Okay. What about important limits or things to avoid completely?
We mentioned alcohol already. Complete avoidance is the only safe approach. No amount is proven safe. Caffeine should be limited, generally to around 200 to 300 milligrams per day. That's roughly 1 or 2 8-ounce cups of coffee, depending on the boost strength. High caffeine intake has been linked to miscarriage and low birth weight.
Good to have a number for caffeine. What factors can influence a client's nutrition during pregnancy that nurses should consider during their assessment? It's not always straightforward.
Absolutely not. Many factors play a role. Age is one. Adolescents have different needs than older adults. Nutritional knowledge: does the client understand what healthy eating in pregnancy looks like? Socioeconomic status is huge: access to healthy food, affordability, exercise habits influence needs, and cultural or religious practices can significantly dictate dietary choices. You need to assess these factors to provide relevant counseling.
Right. It needs to be individualized. And what about specific nutritional risk factors that nurses should be particularly aware of? Things that might flag a need for extra support or referral.
Definitely screen for these. Low socioeconomic status, again, adolescents. Following a strict vegetarian or vegan diet requires careful planning to ensure adequate protein, iron, B12, calcium, and zinc. History of bariatric surgery can cause malabsorption issues. Severe nausea and vomiting of pregnancy, hyperemesis gravidarum, obviously impacts intake. Pre-existing anemia, being significantly underweight or overweight before pregnancy. History of eating disorders.
What about pica?
Yes, pica is a big one. Also, having closely spaced pregnancies, multiparity, or carrying multiples, multifetal pregnancy, increases nutritional demands significantly. And of course, substance abuse interferes with nutrient absorption and overall health. Each of these situations requires a closer look and potentially tailored interventions or referral to a dietitian.
Pica is fascinating and definitely concerning. What exactly is it, and what does it signal to you as a nurse when a client reports this?
Pica is the persistent craving for and compulsive consumption of non-food substances that have no nutritional value. Common examples include dirt, clay, laundry starch, ice in excessive amounts called pogophagia, burnt matches, coffee grounds, baking soda, even cigarette ashes. While the exact cause isn't always clear, it's often strongly linked to deficiencies, particularly iron deficiency anemia, but also sometimes zinc deficiency or general malnutrition.
So if a patient mentions craving ice or dirt,
It should immediately trigger a red flag for you as the nurse. Don't dismiss it as just a weird craving. It signals the need for a deeper dive into the client's dietary habits, a thorough nutritional assessment, and very likely lab work to check for anemia and other deficiencies. It suggests that something significant is missing from their diet or isn't being absorbed properly.
this truly raises an important point about how holistic assessment of a pregnant client really connects all these dots, from the physical adaptations we discussed to the lab results, the psychosocial factors like socioeconomic status, and how nutrition underpins and impacts every single one of those areas.
Precisely. It's about seeing the whole person, the whole picture, not just treating isolated symptoms or lab values. Everything is interconnected in pregnancy.
We've covered a tremendous amount today. We've journeyed through the truly astounding physiological adaptations the body makes during pregnancy. We've demystified the crucial aspects of antepartum assessment, from confirming pregnancy and calculating dates to understanding routine labs and vital calculations like GTPL. And we've explored the cornerstone of maternal-fetal health, nutrition. You should now have a much deeper understanding of this incredible interplay of systems and the critical nursing interventions involved at each step.
Absolutely. This deep dive hopefully has equipped you with specific, actionable knowledge. Things like recognizing the subtle differences between presumptive, probable, and positive signs of pregnancy, knowing how to calculate an EDD using Nagel's rule, understanding why ROGAM is so vital for Rh-negative clients, and critically being able to identify those danger signs that require immediate action. This isn't just abstract theory, it's the foundational blueprint for the compassionate, informed, and safe care that you, as future nurses, will deliver every single day.
So, to leave you with something to think about, considering the body's profound, almost innate ability to adapt so radically during pregnancy, what might be the next frontier in personalized antepartum care? Can we move beyond our current assessment methods? Could we truly leverage a deeper, maybe even molecular understanding of these individual physiological shifts to actually predict and prevent complications before they happen? Imagine offering a truly tailored proactive journey for every single pregnant client based on their unique adaptive profile. What would that look like? That's something for you to mull over as you continue your studies and think about the future of nursing and maternity care.